people around Asia, and good morning in the West. So I'm Dr. Naveen Kumar Mishra from Kathmandu Medical College, practicing pulmonology, and I'm also a web member of ATS. Today, I'll be moderating this session together with Dr. S. He has helped me throughout planning this webinar or panel discussion on barriers and challenges in managing ILD, progressive pulmonary fibrosis in Southeast Asia. So we have three experts who are based in Asia practicing ILD for quite a long time, and they have significant experience and contribution in the field of ILD. So our first speaker will be Dr. Saurabh, who is AP at All India Institute of Medical Sciences, followed by Professor Guleria, who was ex-HOD and Director of HOD, AIIMS, New Delhi. Now he is at Medanta, New Delhi itself. And finally, Dr. Bhatta is a professor at BPKIHS, Dharan, Nepal, who will be talking on comorbidities associated with ILD. So we will begin with Dr. Saurabh. Dr. Saurabh, over to you.
Thank you, Dr. Naveen. So I'll just start my screen sharing. Okay. Good evening, everyone. So in next 15 minutes, we will be discussing about the barriers and challenges in establishing the diagnosis of progressive pulmonary fibrosis in resource-limited settings. So if we talk about pulmonary fibrosis, there have been a lot of terms which have evolved over the last few years. So one common term is ILD, which we all understand. And the most common type of idiopathic ILD is IPF. Now there are two new terms which have come in last decade. One is the PF-ILD, that is the progressive fibrosing ILD, which was a common term being used. And in 2022, ATS has introduced a new term that is called as the PPF, or the progressive pulmonary fibrosis. So in next 15 minutes, we will be discussing how do we diagnose progressive pulmonary fibrosis, and what are the challenges in our settings to establish a diagnosis of progressive pulmonary fibrosis, and what is the importance of this entity. So, I'll begin with the case where I'll try to point out the things which are required to establish a diagnosis of PPF, and then at the end we'll see that how can we improve our diagnosis. So this patient was a 48-year-old lady who presented in 2016 with dyspnea and dry cough. A CT scan was done, which was reported as ILD without any specific pattern given to it. So you can see the images on the scan on the screen. There are few nodules, few areas of patchy consolidation, and some areas of ground glass. On evaluation, this lady was found to be ANA positive. However, other workup was negative. Her lung function showed a FVC of 60% of predicted, DLCO of 42%, and a 6-minute walk distance of 250 meters. The differentials kept with this scan and the clinical picture was either a CTD ILD or a sarcoidosis. A TBLB was performed, and the TBLB was reported by the pathologist as a NSIP pattern ILD. Because it was thought to be an inflammatory ILD, she was started on steroids along with mycophenolate mofetil. What happened in future? Over the years, she improved. There was some improvement in her cough and dyspnea. Lung function was stable, and there was some improvement in 6-minute walk distance. She was continued on corticosteroids and mycophenolate of 2 grams per day. But if you see the scan now, the scan shows some degree of progression in the fibrosis. This is 2018. Now 2019, she had 3 months history of worsening shortness of breath and cough. She had hypoxemia. The room air saturation was 86%. She had developed worsening of her pulmonary hypertension. There was reduction in lung function, including FVC and DLCO, and reduction in 6-minute walk test. The CT scan showed there was a progression in the opacities on the radiology. So at this point of time, she was started on oxygen. The anti-inflammatory therapies were continued, and pirfenidone, that is antifibrotic drug, was added. So this case actually tells us the history of a typical patient of ILD, which we routinely encounter, which are the slowly progressive type of ILDs rather than very rapidly progressive. This is a an inflammatory ILD. So we will see what PPF is and we'll come back to this case. So the concept of progressive pulmonary fibrosis has come with the idea that there are, historically, we used to think that all ILDs have one diagnosis. Then currently what we went on to that we need to identify these ILDs into different categories like IPF, NSIP, DIP, RBILD. We need to categorize those ILDs. That is mainly that you split the disease into multiple categories. But after you have splitted those disease, what happens at the end in all of these is the fibrosis. So that means after you have splitted those disease, now you have to lump them back, those who have a common behavior, that is progressive pulmonary fibrosis. So initially we diagnose a patient with ILD, we give them a clear diagnosis, whether it is NSIP, whether it is CTD, whether it is hypersensitivity. We treat them accordingly, and at the end, once they show progression of their disease, then we lump them into the category of progressive pulmonary fibrosis. That is the concept of PPF. And why it is important is because fibrosis has been shown to have worse prognosis. So if you look at the PPF, the exact prevalence is not known, but in general, the data has shown that 1/4 to 1/3 of all non-IPF ILDs will actually have a behavior which is compatible with the diagnosis of progressive pulmonary fibrosis. Okay. So the diagnosis of progressive pulmonary fibrosis is made when patients have ILD, that is having radiological evidence of pulmonary fibrosis other than IPF. And if they have any two of the following three criteria, that means clinical worsening of respiratory symptoms, or there is physiological evidence of disease progression by lung function, or there is radiological evidence of disease progression, which is occurring within last 1 year, and there is no alternative explanation. So this slide actually tells us that how should we diagnose progressive pulmonary fibrosis. We have a patient who has ILD over last 1 year who show a progression in either of these 2 out of 3 domain, and we do not have an alternative explanation, then we label that patient as progressive pulmonary fibrosis. So this slide shows the criteria which are used. So for physiological criteria, we can either use an absolute decline in FVC of 5% within last 1 year, or absolute decline of DLCO more than 10%. For radiological criteria, there are various criteria, including increased extent and severity of bronchiectasis, new GGOs, new fine reticulation, increase in the extent or the coarseness of reticulation, new or increased honeycombing, or increased volume loss. But it is very important that we need to exclude alternative explanations of worsening in patients who have a suspected progression. Specifically, patients who have worsening of their respiratory symptoms or DLCO rather than radiology or FVC, they need to be assessed properly for any alternate explanations, because worsening of respiratory symptoms or DLCO can happen because of other things as well. And those who present to us in exacerbations, they should be reassessed after exacerbation for any progression. So what is the burden of ILDs in India? So if we see, this was a study which was published from PGI recently, the crude annual incidence of ILD was 10 to 20 cases per lakh population. And if we look at different ILDs, it is very important for us as Indian or Southeast Asian to understand what is the prevalence of the disease. If you look at the CTD ILDs, the number of cases is 75 to 150,000. IPF, HP, there is a very high number. And if you look at what are the causes of PPF, that means progressive pulmonary fibrosis, almost 50% of CTD ILDs, 30 to 40% CTD ILDs do show a phenotype of progressive pulmonary fibrosis. For hypersensitivity pneumonitis and occupational lung disease, around 50% of these patients will have a behavior which is compatible with PPF. Although sarcoidosis and idiopathic NSIP have less often phenotype as PPF. That means we have this high burden of ILDs, specifically sarcoidosis, CTD ILD, and HP, who have phenotyping as PPF. So we are going to face a large number of patients with progressive pulmonary fibrosis. And if we do not improve our diagnostic ability for PPF, we will be missing these patients and depriving these patients from a proper diagnosis and a proper treatment. So what were the problems which we can point out in the patient which we saw? So in that patient, there was no clear diagnosis of was established because there was no MDD done for that patient. Evaluation by autoantibodies for a patient who had a pattern which was nodule as well as some ground glass and patchy consolidation, autoantibody profile was not done. Third, which is very important, that before a patient of progressive pulmonary fibrosis is prescribed antifibrotics, they need to be treated with the standard of care, which varies depending on diagnosis. But because in our patient, no diagnosis was established, so standard of care was also not prescribed for the patient. And because there was late progression, antifibrotics were added without a standard. So this case, which I have brought here, highlights the importance of a proper diagnosis in a patient with ILD so that we can follow those patients and establish a diagnosis of progressive pulmonary fibrosis. How do we monitor these patients for progression? So very important, it is very important that all ILD patients should be monitored frequently to establish a diagnosis of PPF. So clinical monitoring should be done continuously. Initially, it can be monthly, but then it can be made 2 to 3 months depending upon their symptom profile. The patient should be asked to report back if they have any worsening of their symptoms. Their lung function should be done initially every 3 to 4 months. And if they have a stable disease, then the frequency can be reduced to 6 to 12 months. And a CT scan should be done initially every 6 months if there is a suspicion of progression, or they can be done as needed. And further investigations such as 6-minute walk test, echocardiography, etc., can be done as needed. So once you have this frequency of monitoring established in your profile or your protocol of monitoring ILD, you will be able to pick up patients with progressive pulmonary fibrosis. No. So now we come that once we need to diagnose a patient with PPF, what all we need? We need a patient who has diagnosis of ILD, which is based on a multidisciplinary discussion. We need to show evidence of progression by clinical, radiological, or lung function criteria. And we need to know that this patient has received standard of care. So I will be discussing the problems which we face in our settings in all these three domains, then see how can we improve upon. So first I come to the role of MDD, that means multidisciplinary discussion. A comprehensive MDD should be done, used to establish a prompt and precise diagnosis of ILD. The point is that MDDs should be dedicated exclusively to ILDs, and they should have an adequate caseload to enable regular meetings of those multidisciplinary teams. In these meetings, the data should be presented by the respiratory physicians. The problem with our setting in majority of Southeast Asian countries is that this MDD is missing in most centers, which is very crucial to establish a diagnosis of ILD. Many centers run MDDs which are common, like they have tumor board patients who are lung cancer, those who have other disease. MDD of ILD is kind of integrated into that. However, you need to have dedicated MDDs so that all ILD cases can be chalked out and a proper diagnosis and a label can be given to all of those patients. What actually makes an MDD is minimum you need 2 respiratory physicians, a radiology with ILD expertise, and a histopathologist with ILD expertise. Most of MDDs which even occur in our countries lack these specialists. Most often, a clinician and a radiologist tend to make or reach a conclusion while establishing a diagnosis of ILD in a patient. Rheumatologists, thoracic surgeons, ILD nurse, they are rarely part of MDDs. However, their role cannot be overemphasized, that they need to be part of MDDs to establish a clear-cut diagnosis of a baseline ILD. Now we come to the frequency of MDDs. So there are centers which have MDDs, but they do happen every 2 to 3 months. So that's also a problem, that MDDs have to happen on a regular basis. To happen on irregular basis, the concept of MDD itself goes away. Most often it happens because there are less number of cases or the expert members of the MDD are not available. Also, this point is very important. Many clinicians, including pulmonologists, believe that MDDs are useful for complex, difficult, or unclassifiable cases, but they are not necessary for all ILD cases. However, it has to be re-emphasized that an MDD should be an integral part of every ILD patient, so a correct diagnosis can be established. Now, the problem with our country in MDD related issues are that there is lack of ILD expertise. We don't have pulmonologists, large number who are ILD expertise. Pulmonologists are there, but having a good pathologist as well as a good radiologist and immunologist as part of those MDDs is going to be a problem. There is infrequent meeting of multidisciplinary meetings. Now the question comes, who should present or prepare cases for this? So that gives a logistic and administrative burden to the treating pulmonologist. And most often the centers which do MDDs are already overburdened. And because of this logistic and administrative burden, most of the centers do away with forming an MDD, and they tend to make a diagnosis just by personal discussion. Also, we need to improve technology. That means you can have CT scans on PACS or some system where they can be shared quickly and a diagnosis can be established. And obviously, most of the hospitals need to have a sustainable funding model for MDMs so that they can have a clear-cut diagnosis. Also, as I discussed before, that the ILD nurse or ILD coordinator is not a part of most of the MDDs or most of the ILD teams. However, they need to be there, and the most often reason is insufficient funding from the hospital side or the clinic side, that these nurses are not made part of their MDDs. Also, the system in our country is public as well as private. So what happens that most of the service delivery are very diverse. There's a large population of our country which stays in rural areas, and the clinicians there do not have enough expertise, and they actually need better support from tertiary care or the medical college setup so that they can improve their diagnosis and treatment of ILD. So this system has to be improved so that there is a channel of referral from early center hospitals to tertiary care, and there is a center for referral back to those once a diagnosis has been established and a treatment initiated. Now we need lung function serial assessment for diagnosis of PPF. In our country, we do lack our primary and secondary care hospitals lack a standard spirometer. We need to improve our spirometry testing at various levels, which are crucial for obstructive disease as well as for the diagnosis of ILDs. Diffusion capacity testing is dismal. We need to establish better diffusion capacity testing labs at tertiary and secondary care hospitals so that these patients can be followed up. Also, the training of the technicians who perform spirometry and the medical personnel who interpret need to be improved so that we can have a better outcome of our patients. Also, there is a lack of availability of clinical trial, rheumatology clinics, and other specialists, including cardiology, thoracic surgeons, and lung transplant centers, who are crucial to make a diagnosis of PPF and have a channel of pathway for their further treatment. Also, there is an over-reliance on international statements. So many clinicians in our settings do believe that they do not believe international statements, and they will rely on expert opinion or their colleagues rather than the international statements, because they feel that these statements are difficult to implement in under-resourced settings because of the limited infrastructure and personnel. And thus, our country need to, or our areas need to have local guidelines adopted from the international statements so that they can be modified according to local need, and further things can be added to that. So probably this statement from Mumbai, Dr. Rajan and group is a path for that they have given a statement on PPF and expert group consensus statement. That means we need to have more and more people from the art setup involved in guideline development so that we can have local representation and local issues can be discussed in these consensus guidelines. There's an inherent problem with our healthcare system, which is that 60% of Indian population lives in regional areas, and these people who live in these areas have higher level of disease. They have poor access to specialist care, and they have poor use of healthcare services as compared to people living in metropolitan areas. And this applies not only to diagnosis of PPF or ILD, this applies to a large group of patients. So what we need to do is that we need to reduce the gap between these two so that there is a referral system from primary care to secondary and tertiary and referral back, so that this healthcare system can take care of disease which are progressive like PPF and can be integrated into the pathway. So what are the possible solutions which we can think? One is the established referral system, which is the key for diagnosis and treatment of progressive fibrosis. We can have a model of shared care, which can be utilized based on tele or video conferencing platforms, but we need to have better access to these platforms. We need to have better support and training of these primary and secondary centers by the tertiary care centers and the medical schools. We need to improve our training opportunities in ILD, such as fellowships in ILD and short-term training in centers who are doing good work in ILD, so that this knowledge can be spread and a short-term training can be given to further pulmonologists. Also, development of dedicated radiologists and pathologists, having these as ILD radiologist, ILD pathologist as a subspecialty is crucial for development and for the diagnosis of ILDs being made more appropriately in us. So that's where I'll stop. And so I have to just say that this is an evolving time in the field of ILDs, and this understanding of pulmonary fibrosis is helping us identify new pathways. As clinicians, we need to have our system strengthened, and we need to improve our training as well as referral systems. And with that, we can have better quality research from our settings and make guidelines which are more suitable for our population. That's all from myself. Thank you.
Thank you, Dr. Saurabh. You have pointed out the significance of multidisciplinary discussion and lacuna we are facing. Now we'll move to Professor Guleria, who will discuss to us regarding challenges in managing ILD, especially progressive pulmonary fibrosis in our setting. So over to you, sir.
Thank you. Are my slides visible?
Visible, sir.
So I shall just be addressing the challenges in general, and thank you very much for inviting me. Maybe some of the slides I'll skip because Saurabh has covered a lot as far as the initial part is concerned. So we all know that diffuse parenchymal lung disease follow a huge basket, and IIPs are just one of them, which could be the chronic fibrosing ILDs, the acute subacute fibrosing ILDs, and the smoking-related ILDs. The challenge is that if you look at global trend, there is a change in the diagnosis and the prevalence of various ILDs, which has been reported. Idiopathic interstitial pulmonary fibrosis still being quite common, but also because of increased diagnostic yield, CTD ILD is also coming up. So there has been a change. The IPF, which was relatively more common, is becoming less, and we are seeing relatively other increase in the other types of interstitial lung disease. As was mentioned by Saurabh, in India, hypersensitive pneumonitis and CTD-related ILDs tend to be more common. And this is what has been shown also when we look at the global incidence, that there is a difference in the global incidence and prevalence of ILDs as compared to what is reported in Southeast Asia as compared to the western part of the world. ILD was first reported way back in 1979 when it was called fibrosing alveolitis from PGI Chandigarh. And after that, there have been a number of papers on this, but it is often a neglected disease, and just with the event of the CT scan has actually come more and more into the spotlight. And traditionally, with the overwhelming burden of tuberculosis, which has dominated the respiratory landscape, interstitial lung disease has often been neglected or underdiagnosed. And as was mentioned by Saurabh, that there is a paucity of experts, both pathologists and radiologists, to make a definite diagnosis of interstitial lung disease. So although we talk a lot about MDD, unless we have a radiologist and a pathologist who is an expert in that, we sometimes have an MDD, but the results are very, very non-specific because the specialists are really not there. So ILD has been there for a long time, and if you look at the history, it has evolved over time with various aspects. And the paper in 2014, sarcoidosis was actually the most common ILD, followed by IPF and NSIP. The large study from multicentric trial from 19 centers suggested hypersensitive pneumonitis to be more common, followed by CTD and IPF. And then we also had this study from PGI, which Saurabh referred to, which again found sarcoidosis to be more common. The point that I'm trying to make is, and this is also part of the AIIMS ILD registry, where IIPs were much more common, both retrospectively and prospectively, followed by CTD-related ILD and sarcoidosis. So in a country like India, there is a heterogeneous group of ILDs, which one tends to see with IPF, idiopathic non-specific interstitial pneumonia, COP, and others being common. And that is why it becomes a big challenge for us to not only treat these patients, but to classify them properly when it comes to treating them. And I'll just give you two quick scenarios. This is a 54-year-old male smoker who worked in a steel plant for 20 years. He has coronary artery disease in 2003, had angioplasty, and then presented with progressive shortness of breath, dry cough, no chest pain, palpitation of wheezes, no chest complaints. But he was seen by his cardiologist because he was on his regular follow-up. And a CT scan and X-ray was done, and this was actually diagnosed as ILD with NSIP pattern and started on steroids. Some improvement. This is a chest X-ray, which shows some ground glassing at the base. The CT scan done showed these dense shadows, which was present at the base with some degree of reticular and ground glassing. Patchy areas of reticular and ground glassing seen on the CT scan. He subsequently improved, but developed breathlessness again with resting hypoxemia. And this time, because he was seen by a pulmonologist, a bronchoscopy and a transbronchial lung biopsy was done, which was reported at fibrotic ILDs, UIP pattern, and he was started on pirfenidone, azathioprine, and acetylcysteine without any improvement and told to have a grave prognosis. This is a subsequent X-ray which shows that there's an increase in this shadows which was seen, and a CT shows this ground glassing with some degree of halo around it, and this is the patchy CT scan that one saw. Now, does this patient have a fibrotic ILD, and would we start him on treatment for fibrotic ILD? And is the prognosis that bad? I think the answer to all of this is no, and I think this highlights the problem that one faces in developing countries where we don't have a good multidisciplinary approach. We did not think he had a fibrosing ILD. We treated him properly, and on follow-up, his CT scan showed significant resolution. We also have different types of patients. This is another patient who came from Bihar, a remote part of our country, with shortness of breath for 1.5 years, increasing shortness of breath, no history of cough, wheeze, or hemoptysis. He was a laborer, a chronic smoker, a non-alcoholic, and he had impaired percussion note on the right side with bilateral creps and bronchi. And he was carrying this X-ray which showed these dense shadows with some degree of hyperinflation. The CT showed a pneumothorax also. This was the CT he was carrying with these dense fibrotic areas. You can see the pneumothorax that was there. And he came to us with a pneumothorax on the other side with these dense shadows which showed extensive fibrosis. The lung windows shows these dense areas of fibrosis that this patient had. Now, this patient had ILD with upper lobe involvement, dense fibrosis, and pneumothorax. Again, the issue would be with this patient, we started on antifibrotic, and what could be the cause? Again, he was a laborer who worked in a stone crushing plant for 4 years, 5 years before he had developed these symptoms. And this patient had silicosis with these dense PMFs, which one tends to see also in our setup and can at times confuse the diagnosis. We also have ILD-TB coexistence, and silicotuberculosis has also been reported in the Indian scenario, and that also further makes it more difficult for us to really classify these patients as compared to what is available as far as the Western data is concerned. We're all well aware of the diagnosis of IPF, which came up, and subsequently the update on progressive pulmonary fibrosis, which Saurabh has just mentioned, and which actually classically tries to look at the various criteria. But what it focuses more on is an HRCT pattern and an MDD, followed by either a transbronchial cryobiopsy or a surgical lung biopsy if the diagnosis is not clear, and then to look at an alternate diagnosis. But in our setup, the challenges are that we have a lot of radiologists, a lot of clinicians rely on the chest X-ray, which has a poor sensitivity and specificity, and CT, which is an integral part of the diagnosis, is not that frequently available. And because of the cost, sometimes it gets delayed, and this can lead to delay in the diagnosis or misdiagnosis. Saurabh also mentioned the challenges as far as lung function is concerned, and that is also a huge challenge. So when we start looking at a patient with ILD, we start from the treatment point of view, want to know whether this is IPF, is it a progressive pulmonary fibrosis, or is it a non-IPF ILD, which was requiring immunomodulators and requires treatment with drugs, which could be steroids and others. And this becomes very important in a setup because the prognosis and the response to treatment varies, as I've shown you in the first case that I presented. However, if you look at the setup, most often centers rely on a bronchoscopy to make a definite diagnosis. And various centers look at using a TBLB to make a diagnosis. An open lung biopsy or a cryobiopsy is done in very few centers, and therefore, again, the diagnosis is actually delayed, or one has to make an empirical diagnosis. Coming to the pharmacological therapy, we usually, if you look at most of the patients in Southeast Asia, would probably start off with getting steroids and immunomodulators, followed by antifibrotic therapy. And that's because most data suggests that even in your idiopathic interstitial pneumonias or autoimmune ILDs, there does exist a response to steroids in the early stage, and it's only in the later stage that these go on to extensive fibrosis where antifibrotics had a role. So in our country, we tend to use steroids, immunosuppressants, and biological therapies. But again, because of a lack of awareness, steroids tend to be used much more, along with a combination of immunomodulators, without really following up the proper protocol, as was mentioned by Saurabh, in terms of diagnosing whether this is now becoming a progressive pulmonary fibrosis. We know that antifibrotics, both nintedanib and pirfenidone, are approved both for progressive pulmonary fibrosis and for IPF. There are no head-to-head trials saying that one is better than the other, although data is more strong as far as nintedanib is concerned for progressive pulmonary fibrosis. The ATS-CRS guidelines recommend that both drugs can be used for progressive pulmonary fibrosis and idiopathic pulmonary fibrosis. And there are a large number of studies, the inbuilt studies, which showed that when nintedanib was given in progressive pulmonary interstitial lung disease, they slowed down the rate of progression as far as ILD was concerned. It was not, if you look at the change in the physiological outcome, was not accompanied by meaningful change in measures of quality of life. And I think that's important to keep in mind. And of course, side effects were much more, and that creates a huge problem as far as India is concerned. So what happens in our country is issues in treatment that pirfenidone tends to be given to all patients with idiopathic interstitial pneumonias without really seeing whether this is fibrosing or non-fibrosing ILD. The situation is such that if you get a diagnosis of IPF or ILD, which is suggested to be fibrosing, pirfenidone is started upfront without a proper workup. And most patients do not tolerate the recommended dose of pirfenidone. So it's unclear how effective a low dose is, but you will have many patients who are on just 1200 milligrams. The study from Japan, which initially looked at pirfenidone, showed that even 1800 milligrams was useful or was effective in the Japanese population. The capacity to trial showed that, but again, it's not very clear in our setup whether one can give a lower dose and still halt the progression. And that's why there is a need to do research in these areas. Pirfenidone has also been given early in most of these cases, and there is also a need to really establish that in progressive pulmonary fibrosis, how effective is it in the later stage. Besides the antifibrotic, I think the other very important thing that is not done in our country is to look at the patient as a whole. The holistic treatment is very, very important. A lot of focus is given on the pharmacotherapy, but I think when we talk of progressive pulmonary fibrosis, we're looking at a progressive disease, and therefore pulmonary rehabilitation becomes very, very important. There is a need to develop good pulmonary rehab centers. It can be done through teleconsultations or by having good centers which provide pulmonary rehab. The focus on vaccination, again, something which is not done, and there has to be guidelines for in our country and in various parts of the world for aggressive vaccination for patients who have compromised lungs. And then, of course, the end-of-life decision and oxygen therapy is something that is needed. The other issue is the role of lung transplant, and I think that is something that we need to keep in mind. But in our country, it is still in infancy in Southeast Asia, and therefore a lot of clinicians are not clear when to start discussing the role of lung transplant, when to refer a patient for lung transplant, and what is the survival benefit that lung transplant has. The registry does suggest that now idiopathic interstitial pneumonia is the second most common indication as far as transplant is concerned. But if you look at it, the data from Southeast Asia, the number of transplants done is dismal. And I think this is another area in the therapy of treatment of progressive pulmonary fibrosis that we need to focus on much more as to what we were doing in the past. So we have already guidelines. Dr. Sujit Rajan's guidelines from PPF are there. We have the Indian guidelines for interstitial lung disease, which actually also focuses a lot on what could be done. And here again, pulmonary rehabilitation is stressed upon. Vaccination is stressed upon. Hypoxemia is treatment of hypoxemia and improving quality of life is also stressed upon. And exposure to silica and direct inhalation of tobacco is strongly against that is strongly urged. In the early stage, when you don't have a clarity whether it's fibrotic or non-fibrotic, people do give steroids in lower dose. One could also give mycophenolate mofetil, azathioprine, and cyclophosphamide. And these guidelines really recommend that the ATS guideline should subsequently be followed once you have progressive pulmonary fibrosis. So I'll just sort of stop here, but conclude by saying that ILD is now recognized as not an uncommon disease entity in India as to what it was felt 20 or 30 years ago. Patients still get misdiagnosed and the diagnosis get delayed, and we need to be really clear by an MDD approach, by having good radiologists and pathologists, that this is progressive pulmonary fibrosis, this is non-fibrotic ILD, or this is IPF. And as we already said, we have different etiologies when you start looking at progressive pulmonary fibrosis, IIP, sarcoidosis, hypersensitive pneumonitis, CTD-related ILDs, all are common. And if you look at different registries, you actually get a little bit of varied data suggesting that there is still a comprehensive registry that is needed to really get a clear idea as to what is the prevalence of different types of ILD in our country. Antifibrotics are prescribed without proper workup and often inadequate doses. And that, I think, is the biggest challenge that we face in our country, because the antifibrotics are now being promoted so aggressively that for all ILDs, even when it is not a fibrotic ILD, patients get antifibrotic, and this becomes a huge challenge. And therefore, there is a need to increase awareness of the place of antifibrotic in the management of IIPs, and we need to also focus on the non-pharmacological treatment of the progressive pulmonary fibrosis, because that really does make a difference as far as the quality of life of patients are concerned. So I'll stop here, and thank you very much for giving an opportunity to speak. Thank you.
Thank you, sir, for wonderful highlighting various issues regarding management in our setting. And now I'll move on to Professor Bhatta, who will be talking about challenges in managing comorbidities in Southeast Asia or resource limited setting. So over to you, sir. So you are not audible. Kindly unmute.
Yeah.
Your slides are with you.
Okay. Am I audible now?
Yes.
Yeah, you are.
Yeah, I'll be talking mainly about the managing comorbidities. And these are the most common risk factors, for the ILD, pulmonary fibrosis in South Asian context. Most commonly, it's related with the smoking, as we all know, and then indoor biomass pollution and the industries, especially the silicosis and the industrial issues, and the tuberculosis also is one of the important component here. And talking about the risk factors and what you call the comorbidities, we all know that the ILD have a progressive nature, and most often they present with the worsening of the symptoms. And they are associated with additional comorbidities. They are very important issues, the comorbidities in ILD. And these comorbidities and ILDs are very, very important because there could be a pulmonary comorbidity as well as the extrapulmonary comorbidity. And these comorbidities could be either cause of the disease, or it could be a consequences of the disease itself. And most important issue is, again, here these comorbidities has difficulties in diagnosis. They cause delay in the treatment, and they have profound impact on the prognosis. And they also have an additional physiological and symptomatic effect on the background of the underlying pulmonary fibrosis. Now, if you look at the comorbidities, the most common here we can see is the combined pulmonary fibrosis and emphysema, CPFE. There's one important comorbidity here. It's basically a combination of the pathways of the COPD and ILD both. And it is mostly oftenly seen as the upper lobe emphysema and lower lobe fibrosis. And these patients generally they are more of the male smokers with some pressure flow rates and lung volumes. And the most important issue again in these comorbidities is the pulmonary arterial hypertension. It's seen in more than 50% of the patients, and they shorten the life expectancy. Second common comorbidity is lung cancer. It is almost 7 times much more higher risk for lung cancer in ILD-PPF. The lung cancer are mostly situated in the basal loculations. They are near the fibrotic area, and squamous cell carcinoma is much more common than adenocarcinoma. Second comorbidity, which is generally overlooked, is the sleep disorder breathing, and then it's mostly OSA combination, is because of reduced sleep quality, and it also contributes bilaterally. It causes repetitive injury in the alveolar epithelium as well as the sleep disturbances. Another important comorbidity is most common one is pulmonary hypertension. It's a fibrotic process in the ILD-PPF, is a big ground for the development of PAH. These patients have greater degree of dyspnea. They have a lower tolerance for the physical activity, and these patients are correlated inversely with the lung functions. And mostly these patients will have a very worsened prognosis and their early onset of the CAD and CHF. Now, treatment of underlying cause of hypoxemia is the most important issue here, especially with the supplemental oxygen and optimization of the medical therapy and chronic PAH specific therapy. Other extrapulmonary comorbidities are the coronary artery disease. That's a very, very important issue here. Most patients of the PPF are twice as likely to get CAD as compared to the general population because they share the major risk factors, and 30% of all the patients will have CAD, some amount of the CAD there. Coronary artery calcification of the chest, CT, is very sensitive issue, 80% sensitivity, and one needs to monitor dyslipidemia in these patients, and there's rule out the possibility of the CAD in all ILD-PPF patients which are not improving in the conventional therapy. Second important issue is the usual drugs used to treat the CAD are very safe, but these patients have very high risk of invasive treatments. Other extrapulmonary comorbidities, diabetes, that's very important here again. One needs to check HbA1c regularly in these patients. Metformin is very useful if it's not contraindicated, it's very well tolerated. And diabetes needs to be treated as according to specific clinical guidelines, the way it has been treated normally. And one must understand that anti-diabetic drugs has much more role to play beyond the control of the diabetes in these patients. GRD is a very common comorbidity here. It has again a bilateral relationships, and PPIs can be used for symptom relief, but it's doubtful that whether they stop microaspiration or not. Now, second issue is these comorbidities, extrapulmonary comorbidities, they have much more rapid progression of the disease. They cause reduced quality of life, and they cause increasing hospital admissions and mortality also. Multimorbidity doubles the risk of mortality in these patients. And most of the patients die because of their comorbidities than the ILD-PPF itself. And ILD-PPF is also considered as a disease with extrapulmonary manifestations and the comorbidities. Now, earlier diagnosis of this extrapulmonary comorbidity is very useful because they give us a very large window of opportunity to initiate the treatment as well as to decrease the risk of the progression. Now, if you look at other extrapulmonary comorbidities, neuropsychiatric disease is quite common in these ILD-PPF patients. Most commonly, we require a multidisciplinary approach. Personalized therapeutic strategies are very, very important in this. We can use SSRIs if they are unless contraindicated. But then one has to be very cautious about the drug-drug interaction in these patients. Early diagnosis of these extrapulmonary morbidities, I always told that they are very large window of expressions and initial treatment are very good, and they decrease the progression of the disease. And coming to other extrapulmonary ones, I'll skip this slide. And these have a downward spiral. The patient with extrapulmonary manifestations of this disease, especially in the depression, these patients stay in the home, they have a deconditioning, and later on, they again sit in the home and the disease gets progressed quite well. Now, these comorbidities are multiple, even endocrine morbidities are there, and even the thromboembolism is also there. It's quite common here. Now, there's a concept of the comorbidome. There's a graphic expression of the comorbidities with their 10% prevalence is there. And these comorbidities, if they are inner the circle of the IPF, there are much more chances of the death because of them. Now, another issue, very common issue, is active TB ILD-PPF. This is very common comorbidity in our setup because we do not know what specific interaction between the ILD and TB, still unknown. And this tuberculosis could cause acute exacerbation of ILD-PPF, or ILD-PPF could cause reactivation of the latent TB in this patient, or vice versa. And incidence of TB in ILD-PPF is quite common in our setup. And this poses a lot of diagnostic and therapeutic challenge. Now, sometimes in day-to-day clinical setup, the clinical gaze to the ILD-PPF can be too objective. Sometimes we only look at the dyspnea and respiratory symptoms rather than looking at the complete holistic care of the patient as such, because the patient has respiratory comorbidities, they have neurological comorbidities, systemic comorbidities, and a lot of functional issues are there. Now I'll skip these slides. As Dr. Guleria has said, that we need to have a very holistic approach to the patient with multimorbidity. They have symptoms. These symptoms may be increased because of the comorbidity itself. And comorbidity are the treatable traits in the case of the IPF. Now, these patients with IPF require extensive care, comprehensive care, which extends beyond the pharmacological treatment and requires a multidisciplinary approach. Now, what exactly are the existing gaps in managing comorbidities in our setup? Most often, if you look at the patient's journey in primary healthcare, the clinical presentation of the IPF and PPF is more like it is indistinguishable from any other respiratory disease. It could be like a COPD, it could be like a tuberculosis. Patient goes to the primary health center, and there are a lot of delays, and the people in the clinicians in the primary health centers are much more geared about diagnosing tuberculosis. And then there's a lot of confusion if there is no tuberculosis. There's a lot of confusion what to do after that. Then there are a lot of delays in the patient going to the right center and getting a right diagnostic approach and the definitive diagnosis. And the patient perspective is always that symptoms are very common and non-specific. They generally dismiss the initial symptoms. They already think that it could be because of age or deconditioning. There's a lot of reliance in the alternative medicines. And physician perspectives will be challenging even the most experienced clinicians. There's a lengthy diagnostic process, and it requires a lot of skillful integration of the multiple diagnostic and tests and procedures. And then there's always a limited access for the multidisciplinary team in our setup. And ultimately, it's called a longer time to diagnosis, delayed treatment, very extensive fibrosis, and ultimately, there's a worse outcome. Now, what exactly is the challenges and how do we bridge these challenges? The most important issue is the migration, internal and external migration and exposure to new risk factors. And the policy, the government policy is much more focused only on the programmatic TB management. And the traditional health delivery systems are always traditional. There are no center of excellences. And there is lack of palliative care for the non-cancer lung diseases. There's a palliative care is now slowly developing, especially for the case of the cancer diseases, but there's no specific palliative care in the non-lung cancer diseases, and there's a lack of multidisciplinary approach. Now, how do we make up the gap? The important issue is emergence of new epidemics within syndemic, the post-tubercular ILD-PPF with the multimorbidity. Most of the patients people in our setup, they go for the labor migration. It's a livelihood strategy. But issue is that no person should develop ILD-PPF from going to work, no matter where in the world they live, and no matter what is their level of income. Second issue is about the ILD-PPF with multimorbidity and the return migrant laborers. There are no health system for the return migrant laborers and where they should go and check up their health. Now, how do you bridge the gap? As we know that even to reach the summit of the Mount Everest, you need to bridge the significant gaps with the steep ladders. The whole issue is about we need to redefine the pulmonary disease amidst socio-demographic transition. The pulmonary disease in the South Asian context has to be redefined. We need to redesign the service for delivery of the pulmonary diseases. We need to have much more person-focused care rather than the organ-focused care. We need to address the multimorbidity and frailty in the multidisciplinary approach. That's a very important issue. And we need to develop the collaborative centers for the clinical excellence for pulmonary diseases. And we need to remove the barriers for the clinicians joining the pulmonary academia mostly because the clinicians are reluctant to join the center of excellence because of long career path. There must be a flexibility of the training and accelerated and simplified research approvals. And we need to reallocate the resources for prioritizing the respiratory health of the return migrant workforce. There's a large chunk of the unexplored area, return migrant workforce, because they work in a very dangerous industries outside and they're exposed to much more dust and the fumes and the particles for the ILD development. Now, early diagnosis is very important because there's opportunity for early diagnosis is frequently missed. Patients are being, when they come to the people at advanced disease for the diagnosis. Accurate early diagnosis requires one-stop diagnostic hub with the multi-MDT approach. One needs to identify multimorbidity. Breathlessness management clinic has to be there. These are the things which are lacking in our setup. Pharmacotherapy plus psychosocial interventions. They are very, very important need of the hour. Now we need to have a pragmatic approach to the comorbid ILD. In case of ILD, we should stop only thinking about the lungs in ILD-PPF. We also need to think beyond the lungs. We need to treat the treatable traits. Comorbidities most often are the treatable traits. We need to rejuvenate the brain, appease the mind. It requires a lot of psychotherapy, a lot of pulmonary rehabilitation, spiritual rehabilitation, and a holistic care. And in a one nutshell, we require the multimorbidity in ILD-PPF has to be treated in the multidisciplinary approach. And one for the road. Thank you very much. Thank you for giving this opportunity, and thank you very much. I conclude here. Thank you.
Thank you, sir, for highlighting some major issues we are lacking in our setting. Now we have some questions that I will be addressing to. So first question, we have a question saying, how can we manage intractable cough in ILD? I think Dr. Guleria will answer this question. So sir, please.
Yes, I think one of the most challenging issues that you have is managing intractable cough in patients with ILD, whether it be IPF or the progressive pulmonary fibrosis. One does start with giving cough suppressants. Then pregabalin is another drug which has been given. And more recently, sometimes you land up giving low-dose morphine also because the cough is very, very severe. So it does need a symptomatic treatment. It is a troublesome complaint. Often a cough syrup containing codeine does help, but it's not very freely available. And then you do tend to give drugs like pregabalin and even morphine at low doses if the cough is really intractable.
Sir, and then we also have a question for Dr. Saurabh. How feasible is it performing biopsy to establish diagnosis? Because in our setting, most of the time we use history examination and HRCT and pulmonary function tests. So how common is doing biopsy? Do you have any idea, Dr. Saurabh?
So if you see the ILD registry, which was published from India, the biopsy rate in the initial registry was around 7%, and in the second registry, it was around 15%. So you see, a lot of patients of ILD do not undergo biopsy or are not considered. There are multiple reasons for that. The first thing which we have to understand is that not every ILD patient requires a biopsy. Okay. Those who require biopsy, many of them may not be considered deemed fit for undergoing a biopsy. And many of those who undergo a biopsy, we may still not be able to reach a conclusive diagnosis. So that's very important. So decision of biopsy versus no biopsy has to be taken in the context that how confident we are at a pre-biopsy diagnosis and how a biopsy is going to change our diagnosis based upon that. If you have established a diagnosis of UIP pattern, IPF, without any established cause, then you do not need a biopsy. You have a patient who has established CTD, then you do not need a biopsy. So biopsy is required for the patients where a confident diagnosis has not been made after a clinical history examination, blood evaluation, and a good quality HRCT. If you are not able to reach a diagnosis, you should consider performing a biopsy. And then the decision to biopsy will depend upon patient's fitness, and a consent has to be taken because biopsy has its own complications, including surgical, cryobiopsy, or TBLB. So all those modalities have to be considered before you take up a patient for a biopsy for ILD.
And there is a follow-up question. How about BAL analysis? I think they are pointing to sarcoidosis and chronic HP wherein BAL CD4, CD8 ratios gets deteriorated, and then lymphocytosis. So how frequently do you do this BAL analysis for ILD?
So most often in our setting, the ball fluid contributes to the diagnosis of ILDs, which are like maybe PLCH or PAP or hypersensitivity pneumonitis, where you have lymphocytosis. For sarcoidosis, we don't routinely perform CD4 CD8 ratio, so BAL really does not establish a diagnosis of sarcoidosis. But BAL is useful predominantly to rule out infection or to have uncommon diagnosis. The primary reason we do BAL currently in our setting is predominantly for suspected HP patients, or if we have suspected infection or the common ILDs which I discussed. For patients who have general NSIP with CTDs or patients who have IPF, like looking at the neutrophil count and all, BAL fluid does not really make a big difference to their diagnostic algorithm.
So there is another question for Professor Guleria. What about upfront antifibrotic in non-IPF progressive pulmonary fibrosis like CTD or HP or sarcoidosis? So using antifibrotic agents together with immunosuppressive or immunomodulators, should it be upfront or you have to wait?
I think this is a very good question, because this is a challenge that most clinicians have. Two things. One is, should you straight away, if you have a fibrosing ILD, which you say is related to, let's say, CTD, patient has, let's say, scleroderma, PSS related ILD, and now you say there's more fibrosis. How certain are you that this is all fibrotic based on a CT scan, and there's no element of inflammation where immunomodulators will help you? I don't think we can be that certain, and I think COVID showed us that to a large extent. We had a lot of CT scans, which we thought in COVID were totally fibrotic, and they resolved significantly over time, even without treatment. So I think you often land up actually giving these patients initially the benefit of the doubt, and you would start with immunosuppressants, steroids with an immunomodulator, and then follow them up for about 3 to 6 months, see their lung function and see the state of the CT scan. And if need be, then you could taper off the steroids or put it on a low maintenance dose and add an antifibrotic, either nintedanib or pirfenidone. That is something which is done in day-to-day clinical practice. And subsequently, when you are sure that this is not only fibrotic and the response to the steroids and immunomodulator is not there, you could even taper off and stop them and continue the patient on supportive treatment with the antifibrotics. But if you have an ILD which is not classically IPF, and you have a CTD related ILD, starting upfront and on the first visit with just antifibrotics, you have to be really sure that there's no element of inflammation as far as the patient is concerned, because you would deny the chance of an improvement which may happen with the use of these steroids and immunomodulators.
So we have a question for Professor Bhatta. So is there any modality to quantify fibrosis? Because most of the time what we see, CT scan, they just give you have a traction bronchiectasis or honeycombing or reticulation, but they do not quantify. So when you go for looking for progressive, so how will you say whether this has progressed from before or not? Or is there a role of AI, artificial intelligence, that will come into play?
Yeah, thank you, Dr. Naveen. It's a very interesting question. You know, there are a lot of scoring systems where you can quantify the fibrosis based upon the CT chest, HRCT chest, and then it is always said that around 20% from the beforehand. But for that, you need to have the first CT chest and the regular CT chest for the quantification. And yes, they do have a role of the AI. AI is very good in picking up the signals. You know, they are very good algorithms and software for the picking up the signals and quantification on that. But then again, clinical decision has to be done by the human being, at the consultant, at the clinicians. So AI can augment our, capacity to increase the whatever quantification, but the final decision lies on the clinical decision in the holistic, rather than the organ-based as compared to the person-based, person focus. That's more important. Thank you.
Okay, so I have one more question for Professor Guleria. What's the role of pulmonary vasodilators in idiopathic interstitial pneumonia with pulmonary arterial hypertension? That is group 1.
So there's very limited role that pulmonary vasodilators have. It is mainly because of destruction of the pulmonary capillary blood and hypoxemia-induced vasoconstriction, which causes pulmonary arterial hypertension. There are studies which have used drugs like sildenafil and other vasodilators with limited benefit. There is a trial which was published in NEJM which looked at sildenafil also irrespective of PAH in patients with non-IPF ILDs, and it was a negative study. So the data is not that strong. And I would still say that one has to be careful. There are small case series where sildenafil and other drugs have been used if the pulmonary arterial hypertension is out of proportion to the ILD. So you may have a patient who has, let's say, scleroderma, but has a scleroderma-associated pulmonary arterial hypertension. And you find that the pulmonary arterial hypertension seems to be out of proportion to what you would get with a degree of interstitial lung disease. And if there is a pH which is now looking out of proportion to what would happen because of ILD, one could consider giving pulmonary vasodilators and follow up the patient closely to see whether that helps in improving the shortness of breath and gives symptomatic relief.
Okay, thank you very much, sir. Thank you all the panelists. Thank you, Dr. S and the team, technical team, who has supported planning and concluding this webinar throughout. So we do not have further questions. Thank you, Dr. Saurabh, Dr. Guleria and Dr. Bhatta, and all the participants. I hope you have gained something from today's discussion. Thank you very much, and we'll close the session here. Namaste, everyone.